All right, I want to welcome everyone to the fourth workshop that I'm doing this year. We started out with documentation, and then to start and segue everything for the rest of the talk in the next four segments, we discussed the Brain Well program, which is what really is the thing that differentiates us from other psychiatric practice. And it's only our clinic that offers that. And the first thing we did was talk about genetic testing. Now I'm going to talk about integrative medicine for mental health. But if you go ahead and separate the two, genetic testing and integrative medicine for mental health, it does not work. You have to use what the data is in genetic testing. So this is a lecture on integrative medicine for mental health. How do you define it, though? Straight out of the Integrative Medicine for Mental Health Association is a discipline in psychiatry that supports a whole body approach to mental health disorders, utilizing multiple fields of medicine and nutritional sciences. So we focus on the individual's unique genetics, biochemistry, nutritional status. And with this, we come up with a customized treatment plan that provides a better wellness outcome. So let's talk about the evolution of psychiatric treatment just based on medications. We talk about the first psychiatric medication, which is lithium, invented by John Cade in Australia. He was a psychiatrist. The first antidepressant created was really found by accident. It was an MAOI inhibitor. It was called iproniazid. It was actually used to treat tuberculosis, but then they started noticing these patients were getting perked up and feeling mentally better after they got treated for tuberculosis. And then the next medication in psychiatric treatment was the first antipsychotic in 1952. This was chlorpromazine that came from Benadryl, first used in Paris. Then comes the first TCA. Interestingly enough, this came out of chlorpromazine, and they found that it did induce mania, but then they also realized that it treats depression. Not a popular thing now with tricyclic antidepressants because it's very sedating at high dosages to get the therapeutic effects. And very dangerous and overdose, causes arrhythmia and lots of drug-drug interactions. So in 1987, we started with the first SSRI, which was Prozac. It was great, revolutionary, because it was less dangerous as the previous medications. And yeah, pros were less sedating. The cons were it still took time to build up. 2 weeks for sure. Then you got the GI side effects, and then you got the sexual apathy. Weight gain is a big thing with SSRI, so that's why a lot of people don't like it, especially if they've been on it for too long. Those are the things that happen. So the reason why I got into integrative medicine for mental health is because there's so much treatment resistance in the psychiatric field. I shared this slide previously, but I just want to reiterate again, what is treatment resistance? That's basically failure, medication failure of psychiatric conditions to standard conventional treatment. So in treatment-resistant depression, it's a 50% failure rate. Anxiety, also 50% failure rate. ADHD, 25% failure rate. Bipolar, the most dangerous thing is the depression in the bipolar, and 2/3 failure. And OCD, another 50% failure rate. So there's a lot of room here for improvement by just using standard medications. So let's start with the genetic testing. I like to start with this when it comes to even going into what supplements I give my patients. So this genetic testing, pharmacogenomics, will guide the supplements to give and what to avoid. The first thing I'm going to talk about is the MTHFR gene. And there's a lot of implications to it. It's just not talking about L-methylfolate. So as we know, normal methylation cycle, you have folate that converts the L-methylfolate through the enzyme methylene tetrahydrofolate reductase. And from there, it takes homocysteine, becomes methionine, then becomes SAMe, and then it takes two different routes. Tryptophan becomes serotonin, tyrosine in combination with SAMe becomes dopamine and eventually breaks down to norepinephrine. And what's important to understand is if this cycle does not work right, homocysteine sticks around, which causes a lot of toxicity to the nerve cells and can cause all kinds of issues in the brain, in the vasculature, and causes inflammation. Lots of bad things that can happen if you do not have appropriate methylation. So let's talk about MTHFR deficiency real quickly. The deficiency, the activity can decrease up to 55%, as we discussed in the previous lecture. It can be based on two phenotypes that are abnormal, could be one or two or together. So you combine it up to 55% decrease in methylation, resulting in decrease in L-methylfolate and resulting in all the things that you saw in that cycle, even elevated homocysteine. Standard treatment is 15 milligrams of L-methylfolate daily. And let's talk about the COMT. Let's remember ourselves with that. COMT is the enzyme that breaks down dopamine. It's called catechylcholamine methyl transferase. It also breaks down not only dopamine, but it also breaks down estrogen. Dopamine is found in high levels in the brain because this is what you need to focus and concentrate. So in the brain, you have dopamine. You do have the COMT there that breaks it down to the dopamine degradation molecules. What's important is not so much the normal COMT, but what is low COMT? Low COMT happens when you have too much of the dopamine. And we already discussed that in detail in the previous lecture. So what I just wanted to reiterate, what supplements do we give? Okay. So we give things that'll calm things down. The dopamine can also result in lots of inflammation. So we give antioxidants, vitamin C, D, and zinc. Glutathione is very important. That also cuts down inflammation. Lithium orotate can also tamper the effects of dopamine, as well as increase GABA to compensate for the high dopamine levels in the brain. And we talk about magnesium glycinate or any type of magnesium. What it does, it also tampers the effects of dopamine. How we compensate is we do look at trying to promote increasing the serotonin through tryptophan and 5-HTP, as well as GABA promoters, because what is that? That is an inhibitory neurotransmitter. So that kind of tampers the effects of anything activating in the brain. And I talk about pregnenolone because it actually will also increase GABA through allopregnenolone. So one thing I did want to also share with the pregnenolone, allopregnenolone, there is that medication for postpartum that is really, really expensive. You know, it's a form of pregnenolone, allopregnenolone. And so that is the mechanism and the reason why they use that to treat postpartum depression in women, but it has to be given in the hospital. Okay, so the supplements we need to avoid is, you know, anything that creates dopamine, and they're called phenols, green tea, curcumin, quercetin, amino acids that become dopamine, L-methylfolate. I say that with a caveat. Sometimes if the patient is MTHFR deficient, you have to weigh out the pros and the cons, whether you do want to give them L-methylfolate. As we know, SAMe is also broken down not only to serotonin, but to dopamine. So we try to be careful with not giving too much SAMe. And of course, with that cycle, as already explained, B vitamins, high dose B vitamins are not the greatest for low COMT because you just fueling the fire, creating more dopamine. Is always trying to find the balance between the two of people who may have some deficiencies in these B vitamins. Okay, as we know about the high COMT, this is the warrior gene. One of the things I always try to stress with patients with high COMT is that you can supplement, you can use non-medications, non-narcotics to treat people with high COMT, because this is what I call the ADHD gene, the elevated COMT, which is breaks down in dopamine. So these are the things that we can use: tyrosine, phenylalanine, so they go together. They're in that same cycle. Any of the phenols, That is green tea, curcumin, quercetin, amino acids, even berries. And to reiterate, MTHFR deficiency with COMT activity abnormalities, that makes it even a little bit more complicated, because if you don't think about what the relationship is between the two, you're not going to get the kind of result that you're going to get out of your patients. So if you have MTHFR deficiency with low COMT, you can treat it with L-methylfolate, but I usually give a lower dose, half the dose. However, patients can still get anxious, because what happens, the L-methylfolate makes dopamine. So at that point, I usually give them a super low dose, something like 800 micrograms. But sometimes I totally even just avoid that, because what's going on with MTHFR deficiency with low COMT is the problem is you're not making enough serotonin. So you choose things that's going to stimulate the production of serotonin, which is tryptophan and 5-HTP. And of course, we talk about SSRIs. One thing that we need to do to compensate for people who have problems with elevated dopamine is we increase the serotonin levels. So this is what I call the double whammy gene. MTHFR deficiency with high COMT. These people are low serotonin, dopamine, or epinephrine. However, the issue is also they hypermetabolize dopamine. So they really are just not set to feel good from day one. So in this kind of situation, I usually will add L-methylfolate with the tyrosine. Sometimes I just start with just L-methylfolate and see how they do. And if they're still not doing well with their focus and concentration and energy, then I will add some tyrosine, anywhere between 500 to 1,000 milligrams in the morning. I don't want to give it in the afternoon because it could keep them awake. Okay, so we talked about BDNF. How do we increase that? First thing is lithium. You don't have to give prescription lithium. You can just give the 5 milligrams of lithium orotate, 10, 20. I've done that with patients and they've done extremely well. Intermittent fasting, this is part of like integrative. It's not just medications and supplements. It's integrating the whole thing, lifestyle. This is the diet that works to increase BDNF and increases brain health, as well as interval exercises, increases beta hydroxybutyrate that induces BDNF promoters. So all these things, as you can see, supplements, diet, exercise, are all the things you can do to treat this condition, but it doesn't necessarily have to be where you have to take psychiatric meds, because what we've done here is treating the underlying cause. So how do I know what supplements to give patients? What I've done is I've created this protocol or lab set called Brainwell Labs, and that's where I look at to determine what supplements to give, what medications even to give, as well as correlating the results of the labs with the genetic testing. So that's where it comes to the integrative. This is where you can't just, oh, you're going to treat B12 deficiency. But if you don't concern yourself with maybe they have low COMT, you're going to make that patient more anxious. So in the general things with the, I check basically all the same things as any other medical provider does. CBC with diff, I can find a lot of things that in there that can tell me why people will feel bad or tired. CMP, I need to know, do they have normal kidney functions? Do they have normal liver functions? Because we have to be careful in some of these medications, even supplements. We have to be careful in what to give to patients if they have failure in their liver and their kidneys. As with any standard care in psychiatric treatment, especially if we're going to talk about giving them atypical antipsychotics, we need to check the lipid panel. We need to check the hemoglobin A1C, because we want to know what their metabolic profile is to make sure that they're continuing to be normal while we treat them. And sometimes I'm not against giving psychiatric meds, especially with atypical antipsychotics, because this is very useful in certain genetic conditions, as we discuss. The next thing that I look at, of course, your vitamin levels, B12 folate, but not just that. I look at the metabolism of it. And the homocysteine level. Not 100% that you're going to see elevated homocysteine with MTHFR deficiency. There could be something else brewing in there. But in general, homocysteine can be elevated not only with MTHFR deficiency, the C677T phenotype, but B12 can also cause it, and folate deficiency can also cause it. MMA, which is methylmalonic acid, that is specific for B12. I'm going to talk later about it when I talk about some supplementation B12, why it's important. It's not just saying, okay, their methylmalonic acid is high, and it's because their B12 is low, and then you just automatically give B12. There's a reason why I check these things, and I'm going to discuss that further along. Of course, with vitamin D, lots of mental health issues, even depression. So the latest journal finally proved, giving vitamin D to patients with depression can actually be of benefit. And not just because of, osteoporosis risk and so forth. Vitamin D is considered a hormone as well as an antioxidant because it brings down inflammation. Iron. It's important to check iron in a psych patient. What if that's the only reason why they don't want to do anything? They feel tired. They look depressed. Zinc. Zinc is important because if it's too low, then it can affect hormones, as well as it can have a problem with perpetuating inflammation, because as you know, zinc also is an anti-inflammatory mineral. Magnesium, the same thing. It is pretty critical when I'm looking at somebody who has problems with ADHD, anxiety, PTSD, all those things. So the other thing that we talked about, inflammation, I do check inflammation markers, the C-reactive protein. And one of the things I do like to check is Epstein-Barr virus. It's very common among psychiatric cases. It's a funny virus because your body can still feel like as if it is full of inflammation from acute, although it doesn't represent that way. And what happens when you have too much immune reaction to it? You feel bad, you feel tired. And of course, we have to do drug screen on all patients. We got to really make sure that they're not like using things that is going to prevent your ability to get the patient well. And the last thing that we look at in a brain well panel, which I added recently, is a hormone panel. And when I mean hormone panel, I mean like neuroendocrine. I'm talking about brain hormones, the hormones that are coming from your pituitary gland. They control everything in the periphery, along with studying your sex hormones, your thyroids, and your cortisol. The reason being, seeing that somebody is low hormone in the periphery, I'm not satisfied with that. I need to know, is it from a brain injury? Is it from inflammation? Is it something else that's going on that's preventing the brain from working right? Other things that I do look at also with thyroid hormones is reverse T3. Reverse T3 is inactive. Sometimes when people are complaining of fatigue, reverse T3 is too high, not enough active thyroid hormones, which is T3. Also, I look at Hashimoto's tested through TPO. There's even a correlation with Hashimoto's and vitamin D deficiency. I was able to get somebody's TPO to normal by giving them a higher level of vitamin D or getting them to a higher level of vitamin D. And of course, ACTH and cortisol, we need to check that. Is the patient stressed out with something, but I want to know why your cortisol is high. Is it coming from the brain? Or is it coming from the adrenal gland? Or is it stress? And so let's talk about the first thing that we do in our brain well panel: iron deficiency, fatigue, shortness of breath. You can have cravings for ice. This is very common in pregnant women. They have this concept called pica, but it can also cause restless leg syndrome, which is what exactly happened to a patient when she told me that, yeah, my iron is low and I'm getting restless leg. You don't give them Requip. You treat the problem, the iron deficiency, and let's see if those symptoms go away. So in terms of treating it, iron, 325 milligrams a day, but these are the things you need to tell your patient. Take it on an empty stomach. Don't take it with antacids because they will prevent the absorption. And then Vitamin C does help the absorption of iron. Of course, one of the reasons why some people can't tolerate is constipation, even if you give them stool softeners, but we try. And of course, it does cause black stool, but that's completely harmless. It's just the color of the iron. Lipid panel. I like this in psychiatry because I'm sure everybody will be concerned about looking at their cholesterol being elevated. In psychiatry, I'm more interested in the relationship between cholesterol, mood, and vascular health. In this journal and from Current Psychiatry, they talk about untangling the relationship. What happened is patients with mood disorders have lower cholesterol levels. I saw this in a patient who was taking statins and their cholesterol was 100 and they're complaining of depression. I said, you got to stop that statin. Obviously, it did the job, but it did the job too well. So I said, tell your doctor, your psychiatrist said, stop that. We'll monitor it, but even looking at a cholesterol 250 does not scare me. In fact, I like it there because what happens is it is better for the brain because that's what they use to cover the brain cells. It's a lipid layer. So let's talk about how low cholesterol causes mood disorders. This article talks about how low serotonin function can lead to depression, suicide, impulsivity, and aggression. But the other reason I believe that it happens is because if you give the patient ability to decrease their cholesterol too much, you have basically starved the brain from the cholesterol it needed to make the brain cells healthy. So that's, I think, the other reason why you have depression when you have low cholesterol. And one of the things this study also showed is that out of all the cholesterol, the triglycerides is the one that's elevated. So you can see psychiatric symptoms, syndromes, behaviors associated with low cholesterol. Anxiety, depression, emotional lability, euphoria, impulsivity, irritability, suicide, and aggression. The syndromes you can see diagnosis is anorexia, bipolar, borderline personality, major depressive disorder, and seasonal affective disorder. And the behaviors are pretty bad. They can try to kill themselves, especially with people who are malnourished, and they have potential for violence because of the fact that their judgment is impaired because their brain cells are not healthy from not having enough protection around the brain cells from the cholesterol that makes the lipid layer. How do you treat low cholesterol? Obviously, we want to avoid statins. Okay, once you get down to a pretty good level, like under 200, no more statins for you. And then you do treat them with omega-3 fatty acids, high dose, anywhere between 2,000 to 3,000, sometimes 4,000. Why? Because the body is deprived of this cholesterol, so it needs a source of it outside in order to get the brain cells healthy. Dr. Greenblatt, who taught me about this, he talks about his patient who's 20 years old coming in and out of psych unit trying to kill themselves all the time. Then I don't know what possessed him to check his cholesterol. It was about 100. From there, they treated the low cholesterol, no more suicide, no more depression. So you should try to treat triglycerides because this condition is the one that's really problematic for a lot of people. You know, weight loss, exercise, smoking cessation if you are, alcohol. Alcoholics can have very high triglycerides. So simple treatment, stop your drinking. If the triglycerides are 500, you can give certain things, okay, like low fibrate, along with omega-3 fatty acids and a very low fat diet at that point. B12 deficiency, the main thing is macrocytic anemia. You can see that in liver disease, alcoholics, malabsorption, pernicious anemia, and hypothyroidism. With all that, you can still have psychiatric symptoms if you just think about that cycle, the methylation cycle, as well as physical symptoms. So let's talk about why B12 deficiency can cause depression. This is what we call the pathophysiology of depression. B12 deficiency still causes a buildup of homocysteine. Homocysteine is bad. It impairs the mitochondria, so the mitochondria is no longer giving out energy, as well as it causes oxidative stress. what happens? Cell death in the brain, nerve cell death. So no more neurotransmitter functioning. Things are not coming out, and that's how you get depressed. This was a review article from Curious, October 2020, titled B12 Supplementation, Preventing Onset and Improving Prognosis of Depression. So these are the psychiatric conditions that you can see B12 deficiency. You know, they're really tired, they don't have energy, they can be irritable, they're depressed, changes in the way they think and behave, memory issues, judgment. As we know, there is such a thing as dementia related to B12, as well as eating disorder and weight loss issues. All the physical symptoms, you know, you feel faint headaches, palpitations, tinnitus is a big thing. And we're taught like, look for oral ulcers, pins and needle feeling. So when patients complain of that, you better check their B12. You know, it's not just about eliciting their psychiatric symptoms, abnormalities in the gait, as well as vision disturbances. B12, how do you treat it? Before we talk about that, treating it, according to that article, can delay the onset of depression, improve the effects of the antidepressant. And how does it happen? Because as you know, B12 is involved in that methylation cycle that makes all those good neurotransmitters, as well as B6 and folate. All those B vitamins are very important also in creating all those good feel neurotransmitters. So they can also have an impact on your depression. When it comes to mental health, some people will think, oh, your B12 is normal and it's around 300. But if you're feeling like crap, you're feeling tired, you're feeling depressed, I usually will not hesitate. If it's below 400, I go ahead and just give it to them. And it's usually 1,000 micrograms a day. However, you have to think about, you know, eliciting the history of they had gastric bypass, then you may have to give them injections or sublingual. Also, you have to consider, this is why I talk about the genetics guides our treatment when it comes to even supplements. Low COMT, if you know, you treat the B12 deficiency in low COMT, that will increase all those neurotransmitters. So at times you may have to give just half or not at all, especially if they're not tolerating the B12 replacement because it's making them more anxious. So let's talk about folate deficiency. We can talk about the symptoms, but you know, B12 deficiency and folate deficiency are pretty much all the same, what you see. So one of the things you can see with folate deficiency, as already explained, is homocystinuria. It can cause neural tube defects in the baby, especially if the mom, the pregnant mom, is not taking supplements of folate. Lack of folate in pregnancy will also increase diabetes risk, as well as autism in the child in the long run. One thing we want to stress here is that homocystinuria treatment with folate lowers the stroke risk, but not cardiac events. That's just data we need to know. But even then, we have to think about treating it, because I have patients that came to me because they just wanted their genetics done. And I saw that they were MTHFR deficient, young guy. And I told him, okay, you're feeling good, you don't have depression, but I elicited family history of strokes and things like that. And he told me later, you know, in that same conversation, he's had a history of stroke. So it's very important when people are MTHFR deficient, regardless of whether they feel good or not, you have to do these things. You have to treat it. And of course, maternal folic acid may lower the risk of childhood leukemia. So how do you treat it? I like to go with just diet first, but if it's super low, for myself, is so long as I know that they don't have any issues with low COMT, and then I'm not afraid if it's a folate below 10, just give it to them, because you want the patient to have the ability to make all those good feel neurotransmitters instead of just depriving them of that. Because if they're feeling bad, you might as well treat them. Food sources, green leafy vegetables, fruits, and the liver. Of course, when it comes to supplementation with folate, if they don't have any folate deficiency, then it's not necessarily that you need to treat it, because there can be the risk of cancer. Why? Because that methylation cycle is not just for making our good feel neurotransmitter, it's also used for protein synthesis. Okay, Homocystinuria. So now that we understand that B12, MTHFR, and folate deficiency are the main causes of it, I didn't put here inflammation. That can still happen. The treatment's simple. Treat the B12 deficiency, treat the folate deficiency. If they have MTHFR, give them the L-methylfolate, 15 milligrams. One thing that also is part of the methylation cycle out of the homocysteine comes out glutathione. If you cannot convert the homocysteine to glutathione as well, then you should give them glutathione 500 milligrams twice a day, especially if they're complaining of inflammation, joint pains, if they had EBV, if they've had elevated C-reactive protein. We may not know where the inflammation is coming from, but it's there. So we might as well support the patient's immune system because it's probably running out of gas, and that's why they feel bad. Okay, methylmalonic acid, I checked that. Basically, to look for elevated methylmalonic acid, there's two ways: B12 deficiency, and so give straight up B12 1,000 micrograms. But there's another way we can see where methylmalonic acid is elevated. It is the inability to metabolize B12. So this is when I get perturbed, when I see doctors in weight loss clinics shooting up people with B12. And I'm like, did they even check your ability to metabolize B12? This is very common. If you have MTHFR deficiency, you can at times see they have a poor ability to metabolize B12. So at that point, how do you know that? The B12 is high with elevated methylmalonic acid level. That means it's not working. It's not metabolizing. So at that time, that's when I give methylcobalamin 1,000 micrograms a day instead of regular B12. So, you have to think about it. Think about the correlation and the relationship of these B vitamins, that it's not just about replacing it. You got to know, are they able to metabolize it and convert it to the active form that your body needs? So let's talk about vitamin D deficiency. I think we all know this. In psychiatric symptoms, fatigue, insomnia, depression, you feel weak. So how do I go about that? Anytime at all that I may see a vitamin D level of 60 and below, I automatically treat it. Why? They'll tell you your vitamin D level is normal at 30. But like I said, if you're feeling like crap, you might as well try to bring that level up to the middle of the road. I was taught, treat the patients, not the labs. If the patient is feeling bad, don't deprive them of a potential cause for their depression, whether it's B vitamin deficiency or vitamin D deficiency. So the recommendation I give is usually 50,000 units a week. Why I do this? I have psych patients. They can't think. They can't even think about what is it they need to do that day. Let's make it easy for them. But it's easier to take one pill once a week versus an everyday thing. This molecule needs to be used at times. The reason being, no matter how much vitamin D I give someone, it's still low. The reason why, I believe it's because of the fact that the vitamin D receptor is not working right. There is a result where vitamin D is not absorbed right. At that time, you need to give K2. K2 activates the calcium binding actions of two protein matrix in the bone, the GLA protein and osteocalcin. So it makes the bone just as strong as if it was going to be with the vitamin D. This is a Japanese study. People took K2. They had slower decrease in age-related bone mineral density. So the one thing I look for inflammatory markers is the CRP. Where can you find it? Anytime at all there is inflammation, arthritis, fibromyalgia. I tend to want to think that there are causes of fibromyalgia we just don't know about. So I don't like to tell my patients that, this is it, you got to live with it. I want to be able to find the source if I can, or at least try to get down the symptoms by decreasing the inflammation. Rheumatoid arthritis, viral infections, as well as toxin exposures, heavy metals, glyphosate, all those things can cause inflammation because the body is like thinking this is not normal in my body. So they're going to try to fight that with your immune system. How I treat it? In anti-inflammatories, glutathione, you boost your immune system. The CD and zinc combination, those are all good antioxidants to also fight the inflammation. If you have normal to high COMT, then I do like to also give the quercetin green tea, the berries, because they're full of antioxidants. They're good for you. But if you are low COMT, it may not be the best. Epstein-Barr virus, a lot of doctors don't think anything significant of this. But of course, whether it's like acute or chronic, it can wind up leading to chronic fatigue syndrome and myalgia. They feel bad, and it can last for months. But what I wanted to share with everyone, the article in May 2021, Brain Behavior and Immunity. Having mono in childhood or even adolescence gives you a 40% risk factor of depression. That's pretty scary. Is there a correlation between mono and depression? I say yes. And as we know, the new theory behind depression is inflammation. Inflammation brings down serotonin, brings down dopamine because of the cytokine reaction. So we got to work on taking away that inflammation for your brain to start finally working right. So what are the treatments for mono? It's mainly supportive, fluids, rest, good diet. But you can give antioxidants, glutathione I like, but you can also give N-acetylcysteine. That's also used to treat overdose in Tylenol, but it's a very, very good antioxidant. The combination of CD and zinc, you don't have to take all of them, but you got to take something in that realm. Quercetin is very good. It really does cut down the cytokine reaction, inflammation, as well as green tea. The anti-inflammatory effects of it is in the ECGC part of it. We look at insulin resistance. There is a mental health impact. Let's talk about just a general population. 1/3 of adults have insulin resistance in the United States. So what? We have 300 million, like population. From last time I looked, 100 million have insulin resistance, but that's not even the main impact. Stanford study, September 2021. Insulin resistance doubles the risk of major depressive disorder. But that's not all. 40% of the patients with a mood disorder have insulin resistance. So they kind of go with each other, like one is affecting one and the other. So it's very important that we try to work on decreasing the insulin resistance in these patients. And how do we do that? Of course, we can talk about all the medications related to it, but as far as the purpose of this topic, we're talking about natural things. So chromium piconolate, it binds and activates an insulin receptor to promote insulin action. The study showed 1,000 micrograms a day is helpful to people who have lower insulin sensitivity. Didn't really help with, they had normal insulin sensitivity, but at least there's some data that I normally like to give these to my patients anyways, if they have insulin resistance. Anything I can do to decrease that risk, I would like to do it for my patients. Vitamin D is interesting. This article that I was going through, it is protective in insulin resistance by lowering inflammation. You lower inflammation, you decrease the risk of insulin resistance, because as we know, vitamin D is a good antioxidant. However, another article I did read also that I ain't putting here, that it does affect the beta cells in your pancreas to promote the release of insulin. So if you have problems with weight gain and insulin resistance, you better be checking their vitamin D level. What if they don't have enough? And that's why they're having a risk factor, or that's why they could be having insulin resistance. So we can talk about antidepressant supplements. As we know, L-methylfolate can be just as good to treat antidepressants. Tryptophan, as we know, that becomes the serotonin, and tryptophan becomes 5-HTP. St. John's worts, people ask me questions about that all the time, so I'm going to talk a little bit about that, as well as lithium orotate. How does that become an antidepressant? So I'm not going to talk about L-methylfolate anymore because I think we all know about that. So let's talk about the tryptophan to serotonin conversion. Tryptophan becomes 5-HTP, and 5-HTP becomes serotonin. So there is a difference between 5-HTP and tryptophan. The main difference is tryptophan causes a feedback mechanism that will also prevent the brain from making serotonin. It shuts it off. So you have such a thing called serotonin deficiency syndrome. I like to think of it this way. In mental health and psychiatry, feeling depressed is not about a Prozac deficiency. As you can see, it's because we're lacking serotonin. So people who have serotonin deficiency, they are depressed. They don't feel right. But if you give 5-HTP, it doesn't cause that feedback mechanism. So that's a healthier, safer way to more beneficial to the patient, especially if they are feeling bad and then they need more 5-HTP to promote the synthesis of serotonin. St. John's wort. In the beginning, I loved this supplement, but then we saw that there were a lot of not so great things about it. But what are the good things? It's been shown to be effective than placebo, and it is good for mild to moderate depression. But my recommendation is short-term treatment. The reason being, because they have a lot of side effects, especially if you are also taking an SSRI. Serotonin syndrome has been documented, and it makes you sensitive to sunlight. And this is one of the reasons why I really don't like St. John's wort, because if I am going to give this to someone, I need to know they're not on all these things that can cause drug-drug interaction. Birth control pills, cyclosporine to give to people with transplant, to prevent rejection. Heart medications, digoxin, that's pretty dangerous if you increase that because of what St. John's wort is doing to it. HIV medications makes it ineffective. Cancer medications, warfarin, as we know, that is a blood thinner. And mixing it with St. John's wort, you're going to have probably a high risk of bleed, as well as simvastatin, which is a statin. Also, there's a drug-drug interaction with that. So if you can rule out all these things in a patient, then they can have it if they really don't want to take anything else, because it is effective. It just has a lot of baggage that comes with it. Lithium orotate. Why lithium orotate is a good antidepressant? Well, let's think about this. Lithium deficiency is actually very common. We do need it in the body in small dosages. So one striking study that I ran into, this Japanese study showed when there's lithium in the water, in the community, there was a reduction in suicide rates versus communities that didn't have it. So a couple of things that can explain that. As we know, lithium orotate promotes brain healing by increasing BDNF. But it also decreases the dopamine effects. So it's also good for anxiety. And it inhibits dopamine as well as glutamate. And it promotes the GABA to be released. Side effects. At this low dose, I usually give around 5, 10, maybe 20, which is really nothing compared to what we normally give lithium, as a prescription. And I did the research, and lithium orotate side effects, all I kept coming up with is like lithium carbonate. So there's really not a lot of side effects. And the bad side effects are coming from therapeutic lithium, especially when it's like over the range of where it needs to be. But to be fair, it's not that I don't like lithium. Regular lithium, because that's the only thing sometimes a patient will respond to. Why? It could be because they have altered BDNF or any other thing, but you always have to worry about the renal effects with standard lithium. But when it comes to lithium orotate low dosages, that has not been shown to have an issue. These are the indications for lithium, traumatic brain injury. Even if they don't have altered BDNF, I think it's a good thing because you're just giving them the ability of increasing their brain plasticity. Low COMT, as we can see, it tampers dopamine effects and increases GABA. Mood instability, same thing, decreases dopamine, increases GABA. ADHD, it helps them increase GABA as well as tamper down the effects of the dopamine, especially with people with like low COMT. And that can also cause people to have ADHD. Supplements for anxieties, B vitamins, vitamin E. When you're stressed, the body uses more vitamin E. So replace it. Don't run out of gas when you're going through periods of stress. You're just going to get more anxious. Vitamin C, I thought this was interesting. It clears the body of cortisol, which is your stress hormone, right? Anxiety hormones. GABA, as we know, this is an inhibitory neurotransmitter, tampers down the effects of all the excitatory neurons, or at least counteracts some of those effects with like glutamate. Magnesium. Magnesium works because it decreases the hypothalamic adrenal cycle. And what happens is it decreases cortisol. L-theanine. Everybody else says give L-theanine. How does it cause a decrease in anxiety? It causes decrease in glutamate, or it competes for the glutamate receptor. So pushes the glutamate out, L-theanine comes in there, you don't have the anxiety anymore. Because if you know, glutamate is excitatory. Ashwagandha, this is an interesting supplement. They did studies, it's comparable to lorazepam. And guess what? It's not addictive. And same thing, it causes the decrease in cortisol. So melatonin is a sleep hormone for insomnia. The way to give it is 2 hours before you go into bed, because in normal physiology, that's what happens. 2 hours before going to bed, normal melatonin gets released in the brain. So it takes that long to get that effect of sedation. Usually 2 milligrams, the max is 10. Negative about it is that it can cause rebound if you give too much. So keep it low. But if it's not working, then you're gonna have to think about other things what's causing you to not sleep. Tryptophan. Why tryptophan is good for insomnia is because it becomes melatonin. The Journal of Psychiatry Neuroscience says the recommended dose is 1 gram 45 minutes before bed. But of course, just remember, when you give too much tryptophan, it causes the feedback mechanism. So when you start to feel that way, you're going to have to just like no more tryptophan. But these were the things that I researched in what natural supplements we can use to decrease in insomnia, which is melatonin and tryptophan. Magnesium. Magnesium, you don't just tell the patient take magnesium because they have insomnia. You have to use threonate. The reason being is because this is the only magnesium that will cross the blood-brain barrier to cause sedation and to help them sleep. Okay, ADHD supplements. Since we talked about all the other supplements, what I'm doing now is just general things that I will give to patients, but knowing all the benefits of those supplements, why lithium erytate will work. Tyrosine, especially with patients at high COMT, you want to replace the dopamine the right way. I have patients who are actually not on any psychiatric medications or stimulants, but they're taking nothing but natural supplements to support their dopamine, and they're doing fine with their attention. Magnesium, we know that helps calm things down. Fish oil, when you have not enough cholesterol in the body, the brain is not healthy, you can have symptoms of ADHD. That's why you would give those things, or omegas. Probiotics. The whole idea is everything comes from the gut. If your gut is not healthy, that's going to the brain. So you need your gut healthy because that's what's feeding it. Zinc. Zinc is interesting because there's supposed to be a study in Michigan where there was way too much copper in the water. And the kids were having, high risk of ADHD. Zinc actually brings down the effects of copper. So zinc has more than just antioxidant effects. Zinc can also decrease that risk, but I don't check copper regularly, but I think it's better to just give than not to give if you think it's appropriate. Supplements for self-harm and suicidal ideation. You may not think that there are, but there are options out there. We need to focus on brain health. As mentioned earlier, the fish oil, the probiotics, the antioxidants, but at times you may still want to give psychiatric medications, which, I'm not against. These are the good ones. Naltrexone that blocks the dopamine, beta blockers, alpha agonists. Brain health supplements in general, probiotics, fish oil, zinc, lithium. And the reason why I say this to anybody for taking brain health supplements, it can be used for anything: ADHD, problems with dementia, memory fog, COVID, all those things can cause a lot of problems in the brain. Taking these supplements will only help, not hurt, but you got to take it long term. I tell my patients, if you're taking supplements, sometimes you got to take it indefinitely, especially when they have a clinical condition like genetic issues. So, with patient with L-methylfolate deficiency or MTHFR deficiency, you can't stop taking your L-methylfolate. Or even with altered BDNF, you can't stop taking your lithium orotate. Can you stop the others? Maybe you can, depending on what level you get them to. That's normal. So this is the talk on integrative medicine for mental health. I mean, I just touched on the surface about the benefits, and a lot of you have been asking me about a lecture for this, like what I do and what I give. So as you can see, it's not just, okay, I have to give you this because you're feeling this. No, correlate it with genetics, we correlate it with labs, and then you give the patient the best chance of a treatment plan that is the best for them. I think we're out of time. So if you guys have any questions, feel free to email me. And when is our next talk? May 19th, that is about TMS. So that's the third component of the Brainwell program. So we got through genetics, and this time integrative medicine for mental health, talking about supplements and what we need to do. So third thing is TMS. That'll be fun because there's lots of things that people don't quite know about TMS that are actually more beneficial for them for brain healing. Okay. All right. Thank you, everybody, for making it. And we'll see you next time.